So we speak about rotator cuff, and we will start about the early history and the open repair, the arthroscopic surgery, then the current concept and the results of the surgery, and finally the biological part. So the history is very important because we need to realize, the complete flow regarding the rotator cuff that was first described in 1778 by Alexander Monro, that described a cuff tear, and then in cadavers in 1834, John Smith described the first series. And then several authors, they try to find the reason why the shoulder can be painful, maybe the elongation of the biceps, the calcification, or the rotator cuff. But finally, they start to realize that the cuff was one of the main sources. And we had the first series of cuff repaired open, for sure, by Georg von Perthes in the Bonn University. And almost 30 years after Codman, he reported a series of cuff tear repaired with staples. And so we come to the true surgical treatment, the open surgery that was highlighted by McLaughlin, that teach us how to repair the retracted lesion, and the Berry from France explain us how to do something that we know as interval slide technique, that was the advancement musculaire. Finally, Charles Liniar described the acromioplasty, and Luz Bigliani the revision of rotator cuff. And Ozaki was the first one to explain us how to use scaffold. Christian Gerber described the tendon transfer in 1988. And then the arthroscopy came out with Michael Burman, the first time describing arthroscopic surgery of the shoulder, but was Watanabe, our master, our teacher with the Atlas of Arthroscopy in 1957. And then the shoulder became important. So James Andrews did the first debridement in the shoulder. Hellman described the subacromial decompression in 1987. And then Watanabe came again describing the posterior portal. And Eugene Wolf, the anterior portals in 1989. So it's not a long time we are working. And if we think about the arthroscopic assisted repair, we go to 1990. So it's almost 30 years ago that we started to use arthroscopy. And then finally, the full arthroscopic repair came out less than 30 years ago with Steve Snyder reporting with this fantastic book, The Technique That Teach Us How to Repair. So the current technique, the gold standard, we can say, is the single row repair. And Burkhardt teach us to do the double row repair as well in 2003. And Park described the transosseous equivalent. And finally, the new development of the technique is the transosseous repair, starting in 2006 the first time, but actually we have the modern transosseous repair with devices that help us a lot in doing our repair in an open fashion. Is a kind of fashion, is a mode, and is something that we can reply the open surgery, even with cross stitches with this X-box modified configuration. So we can fully repair the cuff tear in an old-fashioned way with transosseous tunnel. But what are the results? So we went through 200 years of history of rotator cuff surgery, but the results are different results for this different technique. What are the outcome of the open repair? They are very good. We have a functional improvement and pain relief in 85 to 100% of these people. And the open repair, at the 10 years follow-up, they see a re-rupture of the cuff in 57% of the open treated rotator cuff. That's why we decided to do a study to see at more than 10 years what's going on after arthroscopic repair. And we found that 53% of the cuff only, they were healed at 10 years follow-up. And this is my study that is published in the American Journal of Sports Medicine with ultrasound, but other researchers, they did with MRI, and they had the same results, almost 50% of re-rupture rate. Arthroscopic repair, despite this high number of re-rupture, they have very good satisfaction and functional results, like the one of open surgery. And if we compare mini-open versus arthroscopic repair, no difference in functional outcome, pain, or repair. Open surgery versus any kind of arthroscopic repair, no difference for any repair method. Arthroscopic single versus double row. If we go to the review, systematic review of Macarena's, one of the most important, we see that in 6 of 8 meta-analyses, no difference. In 3 of them, double row provides superior structural healing. But if we see the good paper of Lappner in 2021, this is a randomized controlled trial, single row versus double row, the hypothesis was not supported. No difference in between single row and double row repair. And single row versus transosseous repair, even here, we did a prospective randomized study that was published in the American Journal, and we were not able to find any difference, except just a slightly less pain in the treatment group because probably you don't have any hardware with the transosseous. But again, no difference. Transosseous arthroscopic versus open transosseous, versus transosseous equivalent, no clinical difference. Transosseous arthroscopic, you can only save some money. So finally, in spite of a dramatic increase in the number of publications per year, there is a little evidence that the results of rotator cuff repair are improving. So if you treat the rotator cuff open, mini open, arthroscopic, single row, double row, same clinical results. That's why we need something. We need to look to the future. We need to have a vision. How can we improve our results? Of course, the failure of a cuff is a biological problem. That's why we have to work with regenerative therapies. One of the most well-known is the PRP. PRP is an high platelet concentration that provides a release of various growth factors that are involved in tissue healing and should speed up the tissue healing. You can inject, as we did in our studies, or you can have a suturable PRP. So 2 different methods of using PRP. And in the literature it's really confusing because we have different level studies, different PRP formulation, different surgical technique, different rehabilitation protocols. A lot of studies has been done, but it's very difficult to conclude. The study we did as the hypothesis that the application of PRP improves tendon healing in patients undergoing arthroscopic rotator cuff repair. And the 10 years follow-up has been just published last year in the Arthroscopy Journal, a prospective randomized double-blind controlled trial of 53 patients, in one group treated with PRP after the repair, and in the other just a control group. We did an evaluation in a long term, even with ultrasound and X-rays and a lot of scores. We had 2 homogeneous groups, but finally, in the clinical scores, no difference. You use PRP, you don't use PRP, there is no difference. We can report less pain in the first time post-op, maybe because the PRP released some serotonin, so the patient has a kind of analgesic that you put inside of the joint. The strength was the same in both groups, the repair rate the same in both groups at 10 years. So the conclusion of our study in the long term is that the use of PRP is not effective in improving the long-term clinical and radiological outcomes. And there is a modest reduction of pain in the post-op. But then a lot of other studies with good enough follow-up, they come out. The one of Malavolta, same results of our. PRP did not determine better clinical or structural results. But the other of Wart, PRP is effective in improving constant score when applied to the tendon-bone interface. But finally, is not cost-effective from an economic point of view. More recently, 2021, things are changing because research is ongoing and we see things really changing. In this systematic review, PRP seems to significantly reduce the long-term retear rate. Of course, this is a systematic review. For instance, my randomized controlled trial didn't find any difference, but that's the up-to-date on PRP. So PRP still needs to be studied. Regarding the scaffold, what we know is that we have different scaffold, the extracellular matrix, the synthetic scaffold, and the bioinductive that are pretty new. The xenograph should be abandoned because of the allergic reaction. If you want to use a cellular human dermal graft, they are working pretty well. But what is interesting now is this bioinductive collagen implant that you put on rotator cuff after your repair. Of course, is an extra cost, but this can create a better healing of the cuff. And this is matter of study, somehow is something interesting that we may look. But another field that I explored that is very exciting is the one of using cells, especially mesenchymal stem cells. In 2013, we had a particular year, 4 different groups all over the world. They look at the shoulder, they look at rotator cuff, long head of the biceps, and the bursa, and all of this group, together with my group, we were able to isolate stem cell, mesenchymal stem cells from rotator cuff and the shoulder as well. And we treated 26 patients. We harvested some tissue from the cuff, the long head of the biceps. We send in the lab, and we find this particular population that has some stemness capacity, like to be multipotent, to differentiate in bone, in adipose tissue, in skeletal muscle. So the idea was we harvest the stem cells from the index surgery, we repair the cuff, we take some tissue, we put in a lab, and then we expand these stem cells up to 100 million, that is the target dose for treatment, and it takes 3 weeks, and then we re-inject these stem cells in the shoulder at 3 weeks after the surgery. But this is not the way we can do it. First, because you have GMP requirements, very tough, then it's a 2-stage procedure, then it's very expensive, can cost up to 30,000 euros per patient. So the other idea is to stimulate the paracrine effect of stem cells. And this is the idea of Dr. Kaplan. That means that if you use some stem cells, they can activate the resident stem cells in the tissue you want to treat. And one of the source that we have is the adipose tissue. So we can take the adipose tissue from the belly of the patient, we can use a device to separate the mesenchymal stem cells, and then we can inject on our repair. We did a study in the lab with this transwell plate. It means it's a plate where you have 2 baskets. In one basket, you put the stem cells from rotator cuff. In the other basket, you put the stem cells from the adipose tissue. They are not in contact, only the medium it links these cells. So if the adipose stem cells, they are boosting, they are enhancing the tendinous stem cells, you have a reaction. And this was like that, because this cluster of adipose tissue, they increases the proliferation rate of the tendon stem cells. And even the vascular endothelial growth factors was increased. That means that you can enhance the healing of the tendon using these adipose tissue stem cells. From this laboratory, then we felt really strong that we can do something from a clinical point of view. So we did this randomized controlled trial that lasted 6 years and was published in March 2022 in American Journal of Sports Medicine. 2 groups. In one group, standard single row repair, as you can see. In the other, we harvested the adipose tissue from the belly. Then we went in a dry condition. You can see here the shaver. You remove the inner of the shaver and it works like a suction device. You remove all the fluid and then you inject these adipose cells in between the cuff and the tuberosity and over the rotator cuff. And this video is not important for the surgical technique, but just to showing you that these adipose cells, they stay there, they do not disappear, so they can work biologically on your repair. So the primary outcome was the improvement of the constant score at 6 months after repair, but then we evaluate the pain, the strength, the MRI, and several scores. Very strict inclusion and exclusion criteria, and that's a procedure flow chart with all the steps where we followed up this series of patients. Finally, we had 44 patients available at the 24 months follow-up. No difference in the 2 groups. We are comparing apple with apples. The primary outcome, we found a statistically significant difference in favor of the treatment group in terms of constant Marley score at 6 months. But in the post follow-up, this difference disappeared. The secondary outcomes The ASE score, the simple shoulder test, and the isometric strength, at 6 months they were improved in the treatment group, but then they were the same. The other pain scores, there were no difference. In the MRI, we had less cases of re-tear in the treatment group, but no statistically significant difference. No complication and adverse event. This is the only one level study in the literature. There is another study, a level 3 of Kim in 2017, that is showing lower return rate with these adipose stem cells. So maybe we have an accelerated repair in the treatment group, and this treatment can be a perspective for early return to work or sports in our patient treated with this technology. So in conclusion, this is really an easy available source of autologous stem cells. It's a closed and sterile system, and we can have a faster recovery of shoulder function. So in conclusion of my lecture, the take-home messages: rotator cuff surgery, whatever kind, can assure a 50% on tendon healing with 80 to 95% of patients satisfied with the clinical results. Actually, the gold standard is an arthroscopic single row repair. Biologics seems to be a nice option to improve our results. PRP results are encouraging, but PRP is not cost-effective. Scaffold bioinductive are appealing, and adipose mesenchymal stem cell are promising, but we are just at the sunrise. I take the chance to invite all of you to the ESCA meeting in May 2024 in Milano, and thank you for your attention.